That's a lot tougher. Yeah. You guys started the recording. A little bit.
Laszlo asked me to kind of review how we do stroke triage. What? Hello? Testing, 1, 2. So Laszlo asked me to review how we do stroke triage in our hospitals, and I wanted to take the opportunity to talk a little bit about why that is so relevant, and kind of review some of the physiology that we need to keep in mind, because I think it's very important to look at that. The problem is that people conflate two groups of patients. And when we started off in Palm Beach County, we had this uniquely poorly designed ordinance that said every patient under 2 hours would go to the primary, even though the comprehensive center would be an hour away, and then if you're beyond some time window, then you would go to the comprehensive center. And obviously it does complete injustice to the patients that are the so-called fast progressor. If you're a slow progressor, like that patient, you can have all the time in the world and you'll be able to be reperfused at 11 hours. But if you're that patient, you are going to be suffering with this transfer delay. And this whole discussion that we've actually had over the past 2 years, and we are leading nationally, I would argue, is how do we treat this patient that's most vulnerable in the system of care? How do we get them to treatment? And in Florida, we've already preempted what is now being shown. This is data that was published at IIC from Stratus, and it's basically looking at real-world experience in 1,000 patients as to how do these processes really work. So it's rather interesting, how short these EMS times are. 8 minutes on average nationally from 911 call to scene. Or then EMS scene arrival to door, 23 minutes. And part of that is actually playing around on the scene, about 15 minutes on average, although we don't have hard data on that, to figure out, what are the patient's meds, what's the history, what's the story, packing them up. And that seems to be a significant opportunity for improvement. Can that time be shortened? The card being one aspect. And then just looking at the difference in the transferred cohort. This is patients who got TPA and mechanical embolectomy. The cohort that was transferred was obviously much, much longer. And there was a significant decrease in good outcomes in the patients who were transferred. The number needed to harm is 18. So that's pretty powerful. And I think that's why this is slowly sinking into the national guidelines, and I'll show you what Brajesh already showed. So this is the same for patients who didn't receive TPA, about, 16 minutes and 75 minutes, and then the drive time. So about around 100 minutes delay for those patients who have to have a transfer. So transfers are bad. We kind of all know that, and even the last stragglers here in Broward County, I think, are understanding that in the EMS system that that's bad. This is the data for the hypothetical bypass calculation from Stratus. And it showed that if you're within 20 miles, only 2 patients were no longer eligible if they're being bypassed within a 20-mile radius. That's a pretty big radius. And the average gain was under about 100 minutes. So you reduced the median puncture time from 240 to 148 minutes with this hypothetical bypass. I think that's pretty exciting. And that's obviously going to be tested in some of the prospective trials like race cats, et cetera. The other thing that I thought was really interesting was this graph, and that is if TPA was missed because a neuro hospital is being bypassed in patients who have a large vessel occlusion. Obviously, this is a selected cohort who are TPA failures. There's no predicted difference. So we don't even know whether in this large vessel occlusion cohort, IV TPA plays any role, but it's clear that delays play a role. So the question is, are we actually barking up the wrong tree if we're thinking about IV TPA, if we have a better way of identifying these large vessel occlusions with a reasonable reliability? And that's really what we're all struggling with, is how do we do that? What's the score that works? Lastly, what I thought was interesting to look at is, where are we on this whole spectrum right now in terms of mechanical embolectomy? So nationally, about 3.75% of all stroke get mechanical embolectomy. In South Florida, some of the data suggests, this is Florida Puerto Rico registry, 12.1%. So if you have centers that offer embolectomy, you will actually significantly increase the number of patients that are selected for treatment. And we also saw that in Stratus. And how you see that is the average stroke severity in the patients who are transferred in is actually higher. It takes a higher trigger for a primary stroke center to identify the patient as an interventional candidate before they actually transfer them out. So I think that's a good experience, and that's what we have to build on. Lastly, the calculations about how far you could really drive. I think this is sort of interesting data from the Calgary group on, does it really make sense to go to these primaries in the overall situation? This is obviously Canada. The same is true if you look at the California modeling in this paper. I encourage everybody to take a look at that. And that assumes a door in, door out time of 20 minutes, even though the actual door in to out time is about 95 minutes. So again, pretty powerful data. What we're all looking for is benchmark data. Stratus gave us some individually. You can look at where are you relative to the cohort. So for us, it's important. What's our door to puncture? 55 minutes. Well, yeah. The Swift Prime average was 90 minutes, and look how it's come down over time. Stratus average was 72 minutes, so that gives you the cohort. But what is it like in my county? That's why it's so important to have those dashboards coming down where we have that. And I think for us, we've already preempted this by about 2 years. Bypass is here to stay within 15 minutes. That's what we've been practicing. And this is where we are right now. These are the interventional centers. I don't know how well that projects. 5 in Miami-Dade, and for Palmetto, they obviously have a different triage algorithm because of their unique situation. I'm speaking of Ritesh because he hadn't made it here. Right now, the way I understand the FOAM-D process is for a FAST-ED score of 5 or greater, they will come and bypass was it 4? Okay, 4 or greater. Okay, so that needs to be updated. They will bypass a primary and go directly to comprehensive. And then it becomes complicated again because there's Miami-Dade EMS and then there's Hialeah. So Hialeah Fire does it different than Miami-Dade EMS. So they obviously bypass, and Miami Fire wants to activate the cath lab team. And I still struggle with that approach because there's no communication about the functional status of the patient. There's no confirmation of the syndrome. They just activate the cath lab team. And there's no negative feedback if they're getting it wrong because they have no skin in the game. So for us, it's $1,200 out the door each time the team comes in. But there's not a good mechanism. So I'm not sure that that's going to be sustainable, and we'll have to see. For Hialeah Fire, right now, it is Dr. Kaushal being called every time. When Wilson comes in, it's going to be him, and we have to see how sustainable that is. This is the Palmetto algorithm. It's obviously very complicated because of the different EMS systems and different FAST scores. And so I really would sum it up as it's really dependent on the interventionalist, and it's also dependent what multimodal imaging he obtains. He does a perfusion on a case-by-case basis. Most of his patients go to the lab on sedation. So that's Miami. Miami is different. Palmetto General is different than our other hospitals. In Broward, again, slightly different situation. Here we've had a triage process for most of the county, I guess excluding Tamarack, for going to comprehensive for all patients under 12 hours. Everybody agrees with that? That's kind of what we have here. And for Palmetto, we have the team activated in from the field if we get a race pre-alert. Now they're supposed to ask, and I'll show you that little form in a moment, are there these additional race plus signs? Is there cortical signs like gaze, aphasia, neglect, and plegia? But right now I'm still only getting them in a fraction of the patients. We're not really getting them. The last case that came in, we didn't have that, right? They just were encoding as a regular stroke alert. And we've used these criteria, we've slightly tweaked them over the years. It was initially 8, now we're down to 6 because of the guidelines. But within the last 8 hours, we activate an interventional alert in parallel to the neurology alert. And then we have kind of a standing order set to order CTA and CT perfusion. But if we're faster than that process, the interventionalist has the right to call them off and take the patient straight to the lab. Or if we're in-house, go straight to the lab. And you may, or if there's known renal insufficiency, like in the last case, we call it off, go straight to the lab. And again, we try to do most of our patients with sedation. And then in Palm Beach, it's the similar EMS process. And very similar process because I've been involved in Delray compared to Florida Medical Center. But the difference that we've tried in Palm Beach is to use this form. And so this form is something that the ED team has with the intent to get them to script and increase our capture of race scores. So they're supposed to put the unit in. This is, for instance, the form for St. Mary's. And then ask them about the overall race score and then go through that. Is the gaze deviation, hemiplegia, aphasia, neglect, is the patient younger than 90? For me, that's very important. I don't know how you guys see that. But the yield of good outcome goes down dramatically over 90. So I'm still not sure. Laszlo has a different view on that. Right? You have your group of 100-year-old stroke survivors. But I actually don't know what the right answer is because there's still benefit. It's just much lower on a much lower level. So is 20% in Stratus it was 26% good outcomes. So is that acceptable? Is that good enough to deploy, a $50,000 procedure or $20,000 or whatever the procedure costs? And then this is, I think, the most important question: is the patient functionally independent? Is the patient in any way impaired? Because I don't want to call in a team for somebody that's bedbound, incontinent, demented. That just makes no sense. And I think, that's our process. If you have those, if yes to all, and then we get a pre-alert text from the ED. So the EDs are relay to get this out to the interventionalist. We don't have to have a separate software, which we don't have. And the goal is obviously to get them in communication and get that back and forth over the radio. As I said, it's a work in progress. And then when that activation comes in, the interventionalist has the right to pre-alert even before the patient hits the door. At St. Mary's, we've had a historically slightly different process. Ali's been heavily using CT perfusion for a number of years now, and we've had CT perfusion protocols on every stroke alert for 24 hours. So it's a lot of utilization, and we reviewed that, and we tried to see, can we fine-tune that a little bit? And over the past 3 months, we've been in a trial called Fast Handy, basically using the FAST score to initiate the initial stroke alert and then go to the HANDE acronym that I'll walk you through in a moment. And that seems to be working slightly better, and we've reduced our utilization. So the HAND is hemiparesis, aphasia, neglect, dizziness, eye deviation. If you have any of those, you get the CT perfusion. Otherwise, you don't. So that's the algorithm for St. Mary's. With the prior, for instance, I've personally had situations where I've had the patient who's had the third CT perfusion in a year and a half with a history of migraines. So when you have these rigid algorithms and they come with focal neurological deficit, it's very easy to over-triage, and it's a millisievert for each one of these studies. So 3, when you're doing all 3, so times 3, that's 9 millisieverts. It's pretty significant over time. So I think it's very important that we continuously reevaluate these processes and look at which one works best, and that's why it's important to share them here. Any questions up to here?
How much has that decreased the usage of St. Mary's?
I can't give you a number. They're tabulating it right now, but I know that there's very few false negatives, which is one of the biggest questions that we had. I think it's at least 50%. So I think it's significant, and we're trying to get a handle of the cost. Maybe Sarah has a better answer for that. Do you?
No, not yet. We're still looking at the study, but we have started to look at the cost associated with that particular workup that beforehand, and we have seen a decline.
Right. And so I don't know if anybody thinks this is going to be a feasible process to get EMS more engaged, like the poor man's Volterra. Is that something that we could make do? But I just don't see that coming back a lot from the paramedics. I don't know if it's them or it's my ED just not doing it, not scripting it.
It's a hard answer. hard question to answer. I mean, you know, we went from paper forms, filling them out initially, to now Pulsera, and it's kind of like Paul's bouncing ball, you know, which is the best thing for them. You know, I think that ultimately whatever's going to replace Medcom in the future, keeping in mind Medcom's an antiquated system, if that replacement is something like Pulsera, then I think the direction is going to be headed right for that.
Right.
But I think I question moving toward Pulsera solely for stroke. I don't know whether that will have enough traction to actually make it happen or not.
Okay. So this is obviously on the hospital side. So the ED charge nurse is asked. They have that next to their radio station. So it's not an onus on the paramedics that can get them to do that. This is really on the hospital side. So A, we capture the form in our medical record, and B, making sure that that is initiated over the radio. Even then, it's not happening. I don't know why.
I don't know what is going on the east side that much, but I know on the west side of town where I am, we may get 15, maybe 20%, if that, the race scores, unless we pry it out.
Right. So this is just a prying tool, really.
Not really.
Well,
I mean, it's actually almost station.
because I found what they told me is like, sometimes we're so close. By the time we get you that, we're rolling out, and you can see them pulling up on the camera, and into the bay, getting out. They're like, we're 2 minutes away. By the time we get you all that, we're here.
Right.
So that's the conversation that I've had with the EMS agencies.
Yeah, but I think that part of that may be an excuse. You know, if culturally they're used to making that call the last 5 minutes before they arrive at the hospital, then that would be your answer. But to think that they couldn't make that call 5 to 10 minutes earlier,
From the scene, really, yeah.
you know, again, you know, our guys tend to be creatures of habit. So the habit typically is you do everything on scene that you need to do, even in the back of the truck. And once that's all done, and now you're driving to the hospital, that's when you pick up the radio and call. And you're right, if you have a 5-minute transport time, you may be there pretty quickly. So it just may be a matter of changing that process.
I think a lot of it has to do with the support from the chiefs and the educators and the emphasis that they put on the education and rollout of race. You know, just watching a video and saying, oh yeah, our whole agency's been trained, isn't as effective as when you have somebody who brings in, you know, the physicians and is constantly educating on this new tool.
Is this script which they're reading or they're asking them over the radio as they're giving their report?
Well,
So basically, everyone encodes as a stroke alert anyway, based on fact, based on Cincinnati. And this is basically, when you get that Cincinnati, you're supposed to trigger and say, hey, you have a race score for me. If it's under 5, okay, we're done. But if it's 5 or greater, then you're on the list.
So you fill in whatever comes from Medcom and whatever isn't there, and that helps.
There's really no reason they can't do this. I mean, and again, it may be a matter of specific to stroke patients because the pre-alert is so important to encourage them to make that call earlier rather than waiting and doing like they've always been doing.
So, when they're at the scene, most of the calls come in when they're en route, not at the scene. Is there a way that we could encourage that they do a report at the scene?
So you have to realize from an evolution of EMS, when 15, 20, 25 years ago, when we made those phone calls to the hospital, it was based upon a bulky MedCore device that was about this big, about this wide, with a flip-up handle and an actual little telephone handset inside it. So we would make those calls from the truck because nobody wanted to carry that thing inside the house. So we've just been doing it this way forever. So to change that idea, change that culture of saying, listen, you guys have a radio on your hip now, and you can reach the hospital on this from inside the house. You just got to do it.
Apparently in Miami, they're still on 800 kilohertz. I mean, they can't do it within more than 3 miles, apparently. I found that interesting. Apparently somebody has 400 kilohertz, somebody has 800, and one is shorter range, and they can only do it within 3 minutes or
I'd have to hear that. I think that's a bunch of BS.
I heard that. Really?
They did say that. I was
Yeah.
there.
I'd have to hear that argument.
I think
Yeah.
But I think a lot of it that has to do with the education, explaining the reasoning behind doing the race and calling it from the field. It's to save time. So even though you think it's just quick, well, I'm just gonna pack up my stuff in 3 or 4 minutes, I'm gonna go in the truck. Well, that's 3 or 4 minutes that the hospital could be clearing a CT scan or getting that race information and contacting the neurointerventionalist if it's a possible LVO. So again, it's all in I think the education that we have to work with.
I found that pre-alert this help. I mean, a good example was Monday, our case with Dr. Mueller. You know, we heard the patient was coming, you know, it just so happens his nephrologist was there. So we had all this information very early, and he's like, okay, I'm coming in. So I had time to get the team together, get our docs to and we were, I mean, like a well-oiled machine. It was just that much more ahead once they came in, once they gave us that information. And I mean, like I said, I was lucky his nephrologist was there because he could give us everything we needed. We made a decision to go straight to the lab as opposed to do a triple scan.
I mean, the Medcom system by design is designed that any rescue unit in the county, from anywhere in the county, can call any hospital in the county at any point in time. It doesn't mean you're 3 miles from the hospital. If you're on scene of a trauma call and you need to have a consult from a trauma doctor because you've got to cut somebody's leg off to get them out of a car, you're not going to wait till you're 3 miles from the hospital to make that call because you can't. You need to be able to reach them right then and there. So I find it hard to believe that anyone would say we can't call you until we're 3 miles away. That's completely against the whole process of what Medcom was designed for.
Right. And I was like, what, really? In the 21st century?
Yeah,
They're like,
I'd have to hear that
we're upgrading.
argument.